Welcome to TCCC-Plus, Day 1, Module 11, about tourniquet conversion. Here we cover telling conversion from replacement, when not to attempt it, the time limits, and doing both techniques safely by protocol. The tourniquet stops a lethal limb bleed, but left on too long, the limb can be lost. This is a skill nobody trained for 20 years, and it is now the one that saves the limb. Take the tourniquet down when you safely can. When things are calmer and evacuation is delayed, you have to decide what to do with it, and the principle is simple. Anyone who can put a tourniquet on should be able to take it off. Despite conversion usually being done in the prolonged field care portion of care, we have it here because we start from the habit of reassessing every tourniquet. The one you applied high and tight under fire when you could not see the wound and could not take your time may no longer be working or may not be the one the casualty needs an hour later. Once you have cover and time, you look again and ask whether it should be converted, replaced, or left exactly where it is. This assessment, whether it is the right time to replace a tourniquet, is likely the most difficult part of this course. There are two different actions, often confused in regards to reassessing and changing hasty high and tight tourniquets out for other means. Conversion means swapping the tourniquet for wound packing and a pressure dressing, then easing it off, turning a tourniquet wound back into a dressed wound. Replacement means placing a deliberate tourniquet 5 to 10 centimeters above the wound, then easing off the original high and tight one. You still have a tourniquet, just a better placed one. Time decides what you are allowed to do safely. At this level, only consider taking a tourniquet down if it has been on less than about 2 hours since application of the tourniquet. Between 2 and 6 hours, conversion is a job for a skilled provider who can monitor the casualty closely afterwards, not a routine field action. Past about 6 hours, you leave it on anyway. The limb damage is done, and releasing it is a hospital decision, with the casualty watched for reperfusion injury, where lots of toxins from the oxygen-starved limb flow back into the body when the tourniquet finally comes off, possibly causing life-threatening cardiac arrhythmias. So, under 2 hours, you may convert if it is otherwise safe. 2 to 6 hours, only a skilled provider with monitoring. Over 6 hours, leave it for hospital. Though we want conversions to be done early or not at all, it is important to consider the safety of this even inside the time window. Leave it and resuscitate first if they lost a lot of blood. Never release a long-standing tourniquet into an empty tank. Fill the casualty first, then release. Leave it if the limb is amputated, if the casualty is in shock, or if you cannot monitor them closely afterwards. And again, never if you are in an unsafe environment. If you are considering converting, use this sequence. First, confirm the casualty is stable, it is tactically sensible, the tourniquet has been on less than 6 hours, and the bleeding is controlled. Remember that the past 2 hours, this is a skilled provider's decision, not yours at this level. Pack the wound and put a compression bandage over it. Then release the original tourniquet slowly, over about a minute, and watch. If the wound stays dry, leave the loosened tourniquet slack on the limb, not removed, mark the time, reassess continuously, and provide pain relief. If the wound rebleeds, the conversion has failed. Retighten the original at once to control the bleeding, and then move to a deliberate replacement above the wound. Do not keep trying to convert a wound that has already rebled. Another alternative is to stage a deliberate tourniquet ready to replace before trying to convert. This is an example of conversion, step by step, using the second alternative, placing a deliberate tourniquet ready to tighten before trying to convert. Pack and pressure dress first, then release the original slowly over a minute, and watch. If the wound is dry, you leave the loosened band slack and keep reassessing. If it rebleeds, this is a failed conversion and you must retighten at once. If you have placed a reserve tourniquet at the deliberate spot 5 to 10 centimeters above the wound, you may use this instead. Here is a video demonstrating tourniquet conversion.
Hi, I'm Xavier, active duty medic. We're going to be learning about the tourniquet conversion process. When you encounter a casualty that is bleeding from a limb that has been controlled by a tourniquet, and you assess the wound to be amenable to a hemostatic or pressure dressing, as well as expecting an extended evacuation period, a tourniquet conversion should be completed. Limb tourniquets and junctional tourniquets should be converted to hemostatic or pressure dressings as soon as possible if 3 criteria are met. the casualty is not in shock, it is possible to monitor the wound closely for bleeding, and the tourniquet is not being used to control bleeding from an amputated extremity. Every effort should be made to convert tourniquets in less than 2 hours if bleeding can be controlled with other means. Do not remove a tourniquet that has been in place more than 6 hours unless close monitoring and lab capability are available. Consider body substance isolation. Next, expose the wound. If not previously exposed, remove clothing and equipment as required. Remove the gauze or hemostatic dressing from its sterile package. If the sterile gauze or dressing is not available, use a clean, dry cloth material. Now, pack the dressing tightly into the wound. Fill and pack the whole wound cavity tightly while keeping firm pressure on the wound. Keep in mind that more than one gauze may be required. You want to ensure the gauze extends 1 to 2 inches above the skin. If the gauze does not extend 1 to 2 inches above the skin, use additional gauze. If a penetrating object is lodged in the casualty's body, bandage it in place. Do not remove the object. Next, remove the pressure bandage from the pouch and packaging. Place the pad or bandage directly on the wound, or any dressing previously applied, continuing to apply direct pressure. If the bandage has a pressure bar, insert the elastic wrap completely into the pressure bar. Pull the bandage tight and reverse it back over the top of the pressure bar, forcing it down onto the pad. Then, wrap the pressure or elastic bandage tightly around the extremity, focusing pressure over the wound and ensuring that the edges of the pad are covered. Secure the hooking ends of the strap or closure bar onto the last wrap of the bandage. Slowly release the tourniquet over a minute while observing the bandage for bleeding. Convert tourniquets in less than 2 hours if possible, but do not remove a tourniquet that has been in place for more than 6 hours unless close monitoring and lab capability are available.
No bleeding.
If bleeding reoccurs, reapply the tourniquet, ensuring bleeding is controlled and the distal pulse is absent.
All right, man, you're looking good. Your leg's not bleeding anymore.
Lastly, document all findings on a DD Form 1380 TCCC casualty card and attach it to the casualty.
Replacement is simpler than conversion. Place a fresh tourniquet 5 to 10 centimeters above the wound on bare skin and tighten it. You will not be able to feel the loss of a pulse or see bleeding stop, since the original tourniquet will already have done this. Then loosen the original high and tight tourniquet. Observe for rebleeding. If rebleeds, tighten original tourniquet and attempt to place a second tourniquet next to the deliberate one. If successful, leave the old one slack, not removed, and mark the time for the new one. Here is a video demonstrating tourniquet replacement.
Hi, I'm Ryan and I'm an active duty 68 whiskey. Today I'm going to show you how to assess your high and tight tourniquet that you previously applied and convert that tourniquet into a deliberate tourniquet. This is done in the tactical field care phase. Consider body substance isolation. If a combat lifesaver is available, direct them to assist. First, expose the injury and assess the bleeding source. Next, assess previously applied tourniquets for effectiveness at controlling bleeding and proximity to the bleeding site. Check for a distal pulse. If the distal pulse is present, attempt additional tightening. If a distal pulse is still present, immediately apply a second tourniquet 2 or 3 inches directly on the skin above the bleeding site, if possible, and tighten. Now, slowly release the original tourniquets over 1 minute. Okay, so I'm going to release this one slowly over 1 minute. Okay. Watch the area where bleeding originally took place, ensuring no bleeding reoccurs. If bleeding reoccurs, immediately retighten initial tourniquet, ensuring bleeding is controlled. And further tighten the newly applied tourniquet. Again, slowly release the original tourniquet over 1 minute until the new tourniquet controls bleeding. Assess the tourniquet, ensuring no rebleeding has occurred. Slide originally placed tourniquets down, but leave it in place proximal to the newly placed tourniquet. If relocated, tourniquets should not be fully tightened, but excess slack should be removed to avoid interfering with future treatments and casualty movement. Remember, annotate the time of the new tourniquet placement on the tourniquet. Document all treatment on a DD Form 1380 TC3 card and attach to the casualty.
There is one rule above all regarding tourniquet care over time. Never loosen and retighten a tourniquet to give the limb a break. You cannot reset the clock that way, and each loosen and retighten only adds another insult by increasing blood loss. Convert it properly or leave it alone. Tourniquet conversion has not traditionally been an ASM skill, but the consensus has shifted hard during the last few years. Anyone who can apply one should be able to convert or replace it, because in a delayed evacuation war, the reassessment is what saves the limb. In your unit, it may be a protocol-dependent or delegated skill. Check local protocols, but learn it. So let's see how tourniquet conversion applies to different phases. Under fire, we never convert. In tactical field care and prolonged care, it is one of the most important skills you have. During evacuation, we monitor and retighten if it bleeds. Looking at common errors, we find removing the tourniquet completely instead of leaving it slack, converting in casualties in shock on an amputation or with no way to monitor, loosening to rest the limb, and not marking the conversion time. Let's recap. First, consider the tactical situation and that you are in a setting where it is safe to replace or convert the tourniquet. Convert only when it is safe for the casualty, when they are stable and can be monitored, there isn't an amputation, they are not in shock, and no move is imminent. After this, consider the timing, that the tourniquet was on less than 2 to 6 hours. Under 2 hours at this level, 2 to 6 hours only a skilled provider with monitoring, over 6 hours hospital. To convert, pack and pressure dress, then release the original slowly. If it rebleeds, the conversion has failed, so retighten the original and move to replacement. To replace, place a deliberate tourniquet 5 to 10 centimeters above the wound, then ease off the original. And never loosen and retighten a tourniquet to rest the limb. Thanks for watching our TCCC-Plus for non-medics Day 1 Module 11 about tourniquet conversion. Next up is Module 12, Head Injuries and Secondary Injuries.